So I'm just speaking about the management of thyroid eye disease. It's a case-based approach. So we know that first we have to categorize the disease: active, inactive, mild, moderate, or severe. This. So, so disease activity and severe. What is disease activity and what is disease severity? So active disease will have inflammatory features and inactive will be having fibrotic features. So this is a clinical activity score based on pain, redness, swelling, and impaired function. So this, from the clinical features itself, you know this is an active disease. So International Thyroid Eye Disease Society has come up with a patient evaluation form which can be used in our clinics, and it is very useful actually. So in this case, it looks inactive, but the patient is having increasing proptosis as well as constant diplopia. So he also belongs to an active disease, but it is a phenotypic variant is different. So he needs treatment. So coming to severity, it is a physical sequelae of activity. It can have cause functional and cosmetic defect. So severity has been divided into sight-threatening, moderate to severe, and mild TOD. The main thing is you have to assess the poor prognostic factors, which I am doing in nowadays. We have to check for TSS receptor antibody, history of radioactive iodine therapy, male sex, age more than 60 years, diabetes, smoker, history of other autoimmune diseases, history of obstructive sleep apnea. This is very, very important to assess the prognosis. So first case, 50 years, female, redness, presented with redness, irritation, edema more in the morning. So this is a clinical picture. Obviously, you can see some sort of fullness, but otherwise eye looks quiet. Now what is it? So I suspected two things. Either it can be related to thyroid or can be related to sinusitis. But however, her thyroid is normal. So I did a CT scan which shows very subtle thickening of inferior rectus and medial rectus and fat predominating. Since it was suggestive of euthyroid ophthalmopathy, I took an endocrine consult and she underwent a thyroid scan, showed a cold nodule and advised thyroidectomy. So this is the way patients are presenting to us. Even though there is no clear-cut signs of disease activity, mild thyroid eye disease presents with this dry eye-like symptoms. So but beware. So we are seeing two patients. One is both are axial proptosis. But always check thyroid. If the thyroid is normal, you have to get a scan done before you put it as euthyroid ophthalmopathy. Otherwise, you can miss things like this. It's a case of intracorneal mass schwannoma. First case, it was a thyroid eye disease. So that's the take-home message. If you see a unilateral proptosis, we know thyroid is the most common cause. But if thyroid is normal, get an imaging done before you label it as euthyroid. Orbital imaging when vision-threatening disease, moderate to severe disease, euthyroid ophthalmopathy before decompression. CT scan is the image of choice. So coming to the second case, so this is, obviously this is an active disease, both eyes, right eye vision is PL, left eye CF 2 meters. He's a known case of hypertension, hyperthyroid, TRAP positive, glaucoma, diabetes, already treated with IVMB. See, she has got many of the risk factors. You should be very careful in treating this patient. Lag of thalmos, corneal ulcer, fundus, you can see disc edema. Scan was suggestive of everything. So what are the concerns in this patient? Thyroid, poor prognostic factors, bilateral compression, status post medial prednisolone, lag of thalmos, corneal ulcer, glaucoma, diabetes, hypertension. She has got all the problems in the eye. So we took a cornea opinion, corneal scraping done, fungal corneal ulcer. So the immediate aim is to protect the cornea before jump into decompression. So I did a regular tarsography will not help. So I did a canthotomy, cantholysis, then I levator recession and then did a tarsography just to protect the cornea. So post tarsography, she has improved, the cornea has improved, then he underwent endoscopic decompression, vision also has improved. This is her 2 weeks post-op, but after tapering the steroids, vision again dropped, then she underwent radiation. After radiation, she developed cataract, she underwent phaco with cataract. Eventually, she did well with squint remaining. She has got 6.9 N6 in the right eye and 6.18 N8. Fundus also has improved, see the improvement in disc edema. So in each case, you need a graded approach. So 2 minutes. So this is another case, 50 years, IVMB 3 grams, proptosis, and again referred because of high risk for decompression. He's a known case of chronic kidney disease on dialysis. So GA is always risky. This is his clinical picture. MRI, again we managed in the same manner, tarsography with the blepharotomy. He has improved once the blepharotomy was done and tarsography was done. and he did well without decompression. So whereas various steroid regimens, oral steroids 1 milligram per kilogram per day, taper over 3 weeks, total period 6 months, 24 weeks, that's 6 months. Then pulse therapy can be given 12 Kahali's regime, that is 500 milligram weekly for 6 weeks, then 250 weekly for 6 weeks. Steroid sparing therapies, then radiation can be given 10 fractions per 2 weeks. But here it is given in steroid responsive compressive optic neuropathy or an alternative acute phase decompression of prolonged steroids. Coming to case 4, he's a 55 years inactive TRO after all the treatment. So she underwent decompression, then followed by squint correction, and then retraction correction. Lid retraction can be corrected in many ways, non-surgical and surgical. Non-surgical filler, Botox, triamcinolone. I'm not going to the details. Levator recession is the surgery. Triamcinolone transconjunctivally can be given. It is a very good, it improves retraction. So to conclude, TAD is a highly stigmatizing disease. Control the inflammation remains the important. And case-based approach is very, very important. Multidisciplinary approach will give you a very good result. And we have run a thyroid eye disease clinic with a group of endocrinologists, rheumatologists, ophthalmologists, radiation oncologists, and ENT surgeons. Thank you.